going to be a good group of people for us to hear from. One, CEO of the National Health Insurance Authority of Ghana, another civil society engagement mechanism for universal health care in Zimbabwe, and then the chief of party medical director for AMREF. 3 good positions to be able to talk to us a little bit about leadership in the response, right? Unfortunately, they're not here yet. So, in the meantime, we're just going to go around and find out who's in this room. Because there might be some leaders here we need to know, right? 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 But first, I want to give you some definitions because I said, okay, they asked me to moderate. And I said, but the idea of this session, leadership framework, and I don't know about you, but I didn't know what it meant. We all have ideas of leadership and we all have ideas of what's a framework, right? So I'm going to give you a definition. Our speakers aren't here, but I'm going to give you a definition of what leadership is. And then we're going to go around. It says leadership is the ability to influence and guide a group of people toward a common goal. That's leadership. We're going to take and influence a group of people toward a common goal. And in this case, we're talking about funding crises and uncertainties in the health response of HIV pandemics, right? So we're going to talk a little bit about leadership, and we're going to have 3 leaders tell us a little bit about their experiences of guiding people toward a common goal. It's not limited to formal positions of authority and can be demonstrated by anyone through actions like setting a positive example and empowering others. And so many of us are used to the leaders being over there and us being over here. So it can be anyone and any one of us. Now, the definition I thought that was interesting was the idea of a framework. Framework is a set of ideas or facts that provide support for something. We can create our own frameworks, right? It's a set of ideas and facts that provide support for something. And frameworks make the development process straightforward so that everybody can kind of see what we're working toward and see what we're working on. So I thought, okay, nice idea. Leadership framework that's going to be helping us understand how we're going to respond to the funding crises and the uncertainties that have now been thrust upon us. And we were going to have 3 people tell us from their perspective what they're doing as leaders. They're not here. So I'm just going to ask us to go around the room and say who we are. We're just going to pass this mic to the person behind you or beside you. And everybody's going to say their first name because we're not going to remember the 4 other names and where they're from. Now, not where you were born, but where you're from. Then you can pick the answer. First name, where you're from. Now, do you want to know titles? Okay, good. First name, where you're from. Pass it around.
Good.
Look at this, starts with It's a real basic task. First name, where you're from. Not certain here. Okay, go ahead.
The R should be out.
Okay.
My name is...
And you can stand up. How about you stand up?
Okay, no problem. Good afternoon. My name... Oh, no greeting. No greeting as well. Okay. My name is Ishmael Pili. From first name only, sorry. My name is Ishmael from Malawi.
I'm Moses, again from Malawi. Kennedy, also from Malawi. I'm passing it.
Good afternoon, everyone. My name is Kukusha Bango from South Africa. Thank you.
Good afternoon, ladies and gentlemen. My name is Enid from Uganda.
Can everybody hear that?
Hello, everyone. My name is Grace. I'm from Uganda.
Victoria, Nigeria.
Daniel, Malawi. Sashobonowo, Burkina Faso.
Josiane Kabore from Burkina Faso. Good afternoon, everyone. I'm Oyin Damola from Nigeria.
Harry from Kenya.
Greetings, everyone. I'm Nesta from Zimbabwe.
Matthew from Zimbabwe.
Nelson from Kenya. Kenya is found in Nairobi.
Paul, Ghana. Eben from Ghana.
My name is Doreen from Tanzania.
Lucy from Tanzania.
Edwin from Nigeria.
Adeni from Nigeria.
Tapua from Lesotho.
I'm Jordan from Cameroon.
I am Hlengiwe from South Africa.
Sanibonani, Nelly, KwaZulu-Natal, South Africa.
Williams, Ghana.
Valerie, Kenya. Susan, Ghana. Rita, Ghana.
Koinsola, Nigeria.
Nafisa, Nigeria.
Agnes from Limpopo, South Africa.
Princess from Ghana.
Doris, Ghana.
There were, I heard 2 countries where there was only one person here. Do you know what they were? Cameroon was one. There was only one person from Burkina? Thank you, there were 2. There was one other one. Huh? Because I'm going to pick on them. They're going to become our panelists. You think I'm kidding? I'm not kidding. It's the 2 of you right here. So come on, come on, come on. Oh, come on. Let's hear it for them. Yeah, come on. Come on, we're going to have some fun. Come on, it's going to be easy. Come on, come on. Wasn't even here. The same session 2 hours ago. And so we just created a panel and we all just talk to each other because we're all experts and we all have expertise and we can do some things. And we know things about these 2 countries. We've heard things about these 2 countries. For example, this country is credited with having reached the 95, 95, 95. Correct? Yes. Okay, now what country is that? Do we know? This country has been credited by the UN by reaching 95, 95, 95. Right? Yeah. Okay? And this is just me. Because, you know, I'm the moderator. We're going to take moderator perspective. This is a country we never hear anything about. Right? I said this is a country we never hear anything about. It's not true, she said. So we're going to get the perspectives. You see, this was just a bias I was just showing you because it depends upon who introduces the conversation, who sets up our understanding of what we're talking about, and how it is presented to us, right? And HIV across the continent has been impacted by those ideas of who thinks what about what country in what situation, who gets the message out, who gets to be the model that gets used. So we're just going to have a little bit of fun here today, and we have two really wonderful people who are here representing their entire universe of their countries, okay? And really, it's just fun. We're going to let them say who they are, what they do, and then we're going to ask them one or two questions, and then we're just going to talk about ourselves, because the real issue is there have been changes that have taken place on the continent due to the funding craziness going on in the United States and the decisions around it. We've been working on issues of sustainability and country ownership and domestic financing and money into health and education budgets for a long time. So aspects of this are not new. What's new is there was a whole bunch of money put in by a whole bunch of countries, and it was used to do a whole bunch of things, and then all of a sudden someone said, we're not going to do that anymore. Without any planning, without any conversation, just said no. That's a big deal. On the other hand, we had three panelists that were going to come here and tell us something. We don't know what they were going to tell us. So now we have two panelists. We've selected them. I've selected them because they're here by themselves. So we're going to let them be leaders for us today. Tell us what they do, and tell us, how has what's gone on in the last year impacted, and just your ideas. How has it impacted? Has it made a difference, and what difference has it made?
I'm not sure if I was expecting this.
You weren't expecting it at all. I made it up.
All right, thank you for giving me the floor, and good afternoon to everybody. So, okay. So my name is Ching Jordan, and I'm representing Centre International de Recherche Enseignement et de Soins, that's CIRES. And our focus actually is on HPV and cervical cancer, and we've been able to integrate the HPV and cervical cancer cascade with women living in HIV. So we have a project that is the C3U project, Combattre le cancer du col de l'utérus en communauté et en clinique. That's the fight against cervical cancer in clinic and communities, where we were able to recruit women from the communities and women from the HIV clinics. They were screened for HPV, and for those who tested positive, they had a follow-up care and treatment depending on the HPV care cascade. And if I can get the moderator's question right, she asked about what has been happening in the past year affected us. So I'll talk about the HIV perspective. So we know with the funding, a lot of the issues, the hold on funding for many projects, specifically because I also happen to be part of the IDEA project, that's the International Epidemiological Database to evaluate AIDS, where we collect like a whole database of people living with HIV and come up with recommendations based on what we find in them. So during this past year, where we had like a hold on the project, we see that a lot of patients or people with HIV were affected. Even the treatment center was affected. And there was a breach in the care cascade. There was a breach in care because many people, even though they say no, the ARVs will still be available, the services that normally are supposed to be provided because the funding is available, people will not work if they are not paid for. And so because of the absence of this funding, there is an absence of the service. And then the people that are supposed to benefit, that's the end users, at the end of the day, they don't get they don't get the care they are supposed to get. So in as much as they tried to bridge the gap, not for it to be very wide, we cannot say it didn't affect. It actually affected us a lot. And in the course of that, we had a lot of new infections, and people were not given the right information on what to do when I'm newly diagnosed. Where do I go to? Who do I meet? Who is going to take care of? How am I going to be walked through the treatment process and everything? So we really see that sustainability, especially in terms of finance, is very important. Our settings, especially where we have very limited resources. I don't know if I addressed your question, or would you like me to add any other thing? All right, thank you very much.
I think she has outdone me, so I feel very, shy coming after her. But my name is Dr. Tapiwa Tarumbiswa. I'm honored to serve as the HIV/AIDS Manager, Head of Program, Ministry of Health, Lesotho. And so wasn't expecting to be a panelist, but I think it's a very important discussion we're having. And so, leadership, you're thrusted into it. And so today, that's our role. So what I'll do is I'll give you a small feel of where we are in the response in Lesotho, what happened in terms of the impact on the HIV response, and what are some of the key lessons we've learned. So I think most importantly, as you rightfully said, we've made significant progress. In terms of the 95s by 2025, Lesotho is at 97, 99. In terms of data from our national spectrum estimates, we have reduced new infections by 83% since 2010. We've also halved our deaths by 50% since 2010. But that said, we are happy of the progress, but there are still some areas of that need to be addressed. So we still have issues in terms of children lagging behind, 0 to 19, men, and also KPs. Our strategic plan is that we have 0 new infections by 2030 and also 0 deaths. So we're not yet there. The point is, as much as we celebrate, there's still quite a bit of work. Now, going to the main discussion, which is the impact, like all other countries, was unexpected, but it had its disruptions, but its positives. And I think the biggest disruptions we faced systematically is on service delivery, naturally. Cutting in testing, cutting in prevention services, disruptions in treatment and care services, etc. initially. But fortunately, Lesotho has been supported by, as you all know, by PEPFAR and the Global Fund. But after the disruptions, we found that CDC continued implementing, which was a significant part of the country. So our capacity to continue doing testing and treatment and care was still maintained. As much as USAID went away, it came back again in July through the Department of State under the waiver implementation approach. So we still have a significant amount of support that comes through the US government, which we appreciate. Lesotho is unique in the sense that as much as these disruptions were there in terms of service delivery, in terms of data systems, in terms of some of the commodities, but we are unique in the sense that 80% of our ARVs are domestically funded, and about 20% or so are through the Global Fund. So in terms of ARVs, despite the stop work orders, we were still able to continue our MMD, etc. Secondly, what's unique about Lesotho is that you find that a lot of the infrastructure is managed and also funded through the government. So clinics did not stop. So we didn't have situations where you had reports of clinics closing, etc. The reality is, yes, there was a significant amount of human resources that was supported by the US government, where when there was the stop work order, a nurse wasn't there, or a counselor or a pharmacist, etc. But what the government did to mitigate that is we basically repositioned some of our staff within the government system to go into the ART clinics. It showed resilience in the system, but it had its challenges in the sense that when you take care of clients, you get used to it. So you find that a lot of the clients who were taken care of by these US support were very proficient at HIV. Then when you bring the government staff, there's still that gap, but still services continued. So we showed a high level of resilience. Another very positive experience we felt as a country is the political will and leadership that was demonstrated. I'll give you a good example. When the human resource cuts were done, the government immediately started to prepare to re-engage those staff under contracts. and money was put aside in the contingency fund. So the government had the ability to be able to if it was to persist, to re-engage all those staff, be it doctors, nurses, pharmacists, but through contracts. Other areas of disruptions, like I said, the M&E system, a lot of it was very dependent of funding. And so initially, there was some challenges in terms of getting data, but that quickly got resolved within 3 weeks or so. So we went back to having a system that was functional. But looking to the future, I think this was an opportune time for us to reflect. It was an expose of where the weaknesses are in the response and what needs to be done in order to sustain. So we take it as a positive. I think also another positive for us is the relationship between the US government and the government of Lesotho. As much as there were disruptions, but there was a lot of communication, a lot of support moving forward. And as we speak, most of the services have been resolved, but yet prevention, as we know, is still not yet there, but the government is doing something to cover that. So in summary, I think the lesson to learn from Lesotho is that this was a positive as much as it was disruptive. It showed critical gaps. The government was very responsive. The role of political leadership and rapid response was evident. I also wanted to underscore the role of the civil society and community structures. As much as we are government, but you found that our civil society, our community structures also responded. So it was one of those situations where the impact was negative, but then because everybody was willing to come to the floor, we were able to mitigate that. Moving forward, I think this is an excellent opportunity for us to really focus on sustainability and be systematic about it. I think one of the key areas which we need to sustain are data systems. You need data to inform the program. You need data to inform your sustainability pivots. You need data for resource allocation. Secondly, a very important aspect of sustainability, surveillance. As we move forward, as much as Lesotho has done so well, the need to focus on surveillance system, especially case-based surveillance, mortality surveillance, is very critical. Commodity security, as much as we have good domestic resources towards our commodities, but it's important for us to now cover the other commodities that are funded by other donors. For example, your lab, your test kits, your viral loads, your AHD commodities, etc., which also are supported significantly by our donors. Moving forward, looking at other areas such as quality assurance. To sustain, you need to have good quality assurance. So if you listen to what I'm saying, you realize that to sustain, it's a health system strengthening game. It's not as much as we think it's always about the program and policies and guidelines and etc. For us to sustain, we need strong, resilient systems. So focusing on those areas, data, supply chain, quality, surveillance, laboratory systems is the name of the game. As much as we still need to put our foot down on gaps in the program such as prevention, we need lenacapavir as quickly as possible. We need to address advanced HIV disease. We need to maintain people retained on ART, HIV drug resistance, so that we don't have emergence of drug resistance moving forward, and DSD models of care, ensuring that we retain those individuals on ART. But I think finally, if I was to give a take-home message, the response has been, really driven by the public health experts. To sustain, it has to be driven by the citizen, by the civil society, by the communities. So I think it's time we all had that serious conversation in terms of moving forward. What do we need to do? Who needs to take leadership positions? And that should be civil society. That should be those community structures. It should be about health systems strengthening. These disruptions have been a benefit. It has given us an opportunity to really rethink what we are doing so that we can sustain the response. I think that's me off the cuff. I didn't I didn't expect anything. I didn't expect to be on this panel. Thank you.
Thank you. Thank you. I want to ask you both then the question because, as we're sitting here listening to them talk, one is describing a setting and a situation where it was disruptive and the service mix did kind of fall apart or be challenged by it. Things did stop happening. And then we heard that happened, but the government jumped in. And then when the government jumped in, though, we just heard the list of all the things that everybody still needs in a place where they've already done 95, 97, 98. And, we would say already they're at the success end of the continuum. So now we have to also think, what were we saying when we said 2030, getting to 95, 95, 95? What then does the system look like in this future going forward? And we just heard the list that we still need everything. And how are we going to get everything funded in this world when maybe the government's not the biggest player in town, and maybe it's collaboration with private sector, public sector, and what does that look like? And so I'm going to ask you both a question. What does happen when the service mix gets disrupted? What do you do? Do people step in and just say, because in the beginning we had nothing, and we were all volunteering, we were all hopping in the whatever van and going out and distributing things, we were bringing everybody in, we were meeting in the church basement, we were gathering, we were doing it all. And we know when these changes happen, some of that still picked up. But we heard some of the service mix fell apart, some of it stopped, but government stepped back in. What happens with the service mix? And what should we focus on when we have this kind of disruption? What should we focus on? Give us two things we should focus on from your experience.
And thank you very much. So I would say we should focus on community engagement, because we've seen that in as much as we cannot take care of people, like we cannot provide services apart from the community. So we need the community to be involved. We need the people themselves to be involved in their own health. And also we should have an avenue where we not only rely on external funding, but even as a government and as a country, we should source for resources that will be able to sustain externally funded projects, even at the country level. Thank you.
So I think the most important thing is we have been pre-warned. COVID warned us. And, we can't continue being, being flat-footed when these events happen. So I think one of the most important things is having clear plans that address these shocks. I'll give you a good example of what I would recommend countries have: emergency funds, whereby whenever there's a disruption, be it a pandemic, be it whatever it may be, there should be resources allocated that should address this. Secondly, I do agree with my colleague that we need to look at domestic sustainable funding mechanisms. In our case, yes, government was willing to step in, but the private sector also tried. So really looking at how else can we fund the HIV response other than the traditional approach that is there. I think we need to also applaud and appreciate our partners. In our case, the US government, the Global Fund have been there for 18 years, but funding is never indefinite. I think it's time we take full responsibility about our response. And so looking forward, what is a sustainable way of funding? Is it an HIV/AIDS fund? Is it, innovative engagement of the private sector? Is it, as she clearly, rightfully said, and I'd say that initially, making sure that the civil society, the communities take response? Because at the end of the day, it's the individual that makes that decision. And if the decision is being made by the individual to either prevent etc., we have better outcomes. And I think also another very important aspect is not just to have plans, but also rehearse, be responsive. It's very good to have these beautiful strategies, these nice SOPs, but when the crisis happens, it's as if we're seeing it for the first time. So really being prepared and really simulating and so that if it ever happens again, it's good. I think finally, what also is important is as countries really affected, especially in Africa and sub-Saharan Africa, really shifting the narrative of where a lot of the manufacturing happens. With COVID, borders got closed. Now we're scampering around for test kits, for ARVs, etc. Countries need to start going into those partnerships with whoever manufactures these things to make those HIV test kits in the country, the condoms, etc. So that if a pandemic happens or if ever there's a crisis, there is a sustainable way of maintaining those critical resources. And then I think finally, the reality is it can't be business as usual. I think at our levels as program managers or heads, we now need to find innovative ways of maintaining the response at a lesser cost. So really cutting the cost of implementation. There's certain things that were, I believe, nice to have, but we have to change. I'll give you a good example. We used to love having these trainings where we bring in 1,000 healthcare workers to a hotel somewhere. Costs us a lot of money. It's time to have those e-learning platforms whereby healthcare workers can continue having continuous medical training on HIV, TB online. It also saves us a lot of money. Also important, as much as we think we're doing a good thing training people, we're disrupting services. We're pulling nurses, doctors, whoever it is away. Whereas when you have these online virtual platforms, it's more cost effective. Yes, it might be quite a lot of money to set it up, but once it's set up, it's easy to do that. So the point is really being critical about how we implement, being frugal, reducing the cost of implementing to government, but still maintaining the quality that is there. So that is, in summary, amongst everything. You caught me off guard, but we were trying to say. So thank you.
Anybody have a question or a comment? An observation? Yes. This is Mr. We remember this is Mr. Ah.
Yeah, Mr. So you can call me Ah. Let me appreciate, of course I came in a little late, but what the father from Lesotho was talking about, what happened after after the stop work order, I think that was incredible for you guys. Our experience in Malawi was almost the same. We also tried to come up with a plan, a contingency plan to make sure we still drive the program forward despite the stop work order. But I'm super impressed with that part where the government had to set aside funds to maintain the staff that were working for the IPs. Let me also just put in something interesting that I heard from the previous session before this one. There's a session where this other lady said the problem we have is that we let these donors come in and they bring in parallel systems that paralyze our own existing systems. I think the stop work order, much as it has hit us hard, but it also has to be a lesson to the African countries that we should stand and learn to be on our own. I've read a number of sessions, including someone speaking saying in Africa we have to push to produce the HIV commodities by ourselves. That's the way to go. In Malawi, I would say the program is doing very, very fine. I wouldn't lie, the 395s, they are very good, but what you guys did is very incredible. But for us, we had to bring in back the government employees that were not too active. The problem is we let these people come in and we give them the control of the program, and we take our own people, we put them aside. I think as governments and whatever we are, the civil society organizations and whatever, we need to change the approach now and put our own people in front of the whole program. So thank you very much for sharing that. I think it's a big lesson for us. Thank you.
Thank you.
Thank you so much, and greetings to you all once again, and thank you so much for your leadership. I think this is what we need to move forward. My name, once again, is Grace Naiga. I lead an organization called UGANET. We are lawyers. We promote social justice in the context of health, HIV, and gender in Uganda. I just wanted to flip it a little bit to the human rights context. Yesterday, in the opening ceremony, the able leader, Honorable Winnie Byanyima, mentioned something that stuck in my head, that human rights are the center of the fight, and we need to enforce those to ensure that we continue with the fight. And I just want to bring it a little bit back home. So I come from a country where HIV is criminalized, and where of recent, as of 2023, we criminalized key communities. And while we are struggling with a funding freeze, those laws in our country have exacerbated the legal barriers, and they have made it quite difficult. As we speak, communities are not able to access treatment because of the fear of being persecuted, but also the stigma and discrimination is at a higher rate. Earlier on in the first session in this room, we're talking about online stigma. So now at end, the communities are not even expecting to be protected because the laws, if anything, are fueling that stigma and discrimination. And when you started this conversation, you asked a question around leadership, and I keep asking, when do we sit as Africa to question ourselves, maybe at the African Union, on how exactly we are handling this and the interventions that can be put in place? When can we have uniform laws? When do we point fingers at our colleagues that are still criminalizing communities? If we are looking at Africa as a continent, I'm sure there are a few countries that are still having these kinds of legal barriers. And why don't we put them to task to explain, if they are saying as governments they are committed to the fight, why then are they persecuting communities and watering down the efforts that would otherwise be supporting the interventions? And I think we need to look at it from that perspective. But also as a lawyer, I know that when we want to hold our governments accountable, it should be from a human rights angle. There's the right to health, which is enshrined in all our constitutions, and we need to hold them accountable from that level. I know from the submissions that were made earlier on, there are some governments that have actually included art and the other services in the healthcare insurance schemes. In some other countries in Africa, we are still grappling to even have something that is similar to health insurance. And I think as the leaders at a regional level, at the continental level, we need to hold each other accountable in that regard. Thank you so much.
Can I respond? One year. Yeah, so I just wanted to appreciate the two speakers, especially my brother from Malawi and also my sister. The point I wanted to put across is that at the end of the day, I appreciate the point of saying donors come in and sometimes, you know, develop parallel systems. But I wanted to, you know, twist it around and say that as governments, we need to take responsibility. We need to take leadership. And it's not just about taking leadership, it's also about leveraging the resources that are there. A lot of these partners are good meaning, but need to be guided. You get what I mean? So the attitude should not be, no, it's these guys, they come in, they set up parallel systems. No, they set up parallel systems because maybe there's something you haven't done. So governments need to be strategic. We have these donors. Let us lead, let us show them what needs to be done, and we will get the best result for our citizens. Then to my colleague from the legal fraternity, I want to challenge and say, yes, hold government accountable, but government can't do everything. The citizen has to take responsibility. So there's also that difficult conversation we need to have. Sometimes we want to say it's government, government should do everything. But the citizen has to take responsibility in terms of their behavior, how they approach things, etc. So that's my contribution on that, to say I totally agree. Governments need to be held accountable. There are gaps that are there, but at the same time, this has to be balanced. It shouldn't be one-sided, and it's always about accountability. It's also about accountability about the citizen.
Thank you very much. I appreciate all the speakers for what they have said. And just to add my voice to what he has said, because he has already amplified everything. We are the people in the government as well. So we cannot keep pointing only to the government. We have the obligation to take action, to take rights for our actions. And since we are the people in the government, they are not as if the government are out of us, but we have to make that influence and we have to bring the change that we seek. Thank you.
So this has been a great panel, wouldn't you say? Fabulous. We got them from the audience. You never know who's sitting in your room and what they bring and what they can share and offer. So first, we just want to say thank you for saying yes, coming forward and sharing your experiences. So please join me in thanking our two panelists. And then I just want to tell you two things. And I appreciate the lawyer, and I agree with you, the conversation about being able to absorb the staff, which is just a whole nother level of conversation. At the Key Populations pre-conference, there was a discussion exactly about whether these issues of key populations are connected to human rights, and where's the protection and justice conversation, and where is the response when we see regressive and oppressive government actions. And it's all over the world. I mean, we could stand here and I could tell you there are 750 laws in the United States against LGBT people. Right now, they exist. HIV is still criminalized in the United States. It's a fact, and it just kind of keeps getting worse. And so these issues get used politically everywhere. And the question is, where is the message and the voice that comes out in a uniform way that says, this is just totally unacceptable, what you're doing? You know, and it's not about, you know, health and well-being. It's actually counter to health and well-being. And so there's some conversation going on, and I think it'll come out of the Accra ICASA that will have to do with some kind of statement that will be being made among communities about when these things happen. Is there a generic, and I mean it in that way, generic message that goes to the heads of state and the heads of parliament that says, this is not what the world does today. We don't do this. We understand things differently. We know things more. This is just not about health and well-being. This is not where our humanity is. So some of that conversation has gone on in pre-conferences and pre-discussions. The other thing I want to tell you is PEPFAR came out of ICASA in Zambia. There was an ICASA in Zambia in about 1997, I think it was. Maybe not. Maybe it was, I don't know when it was, 19, whenever, look it up. It's listed in our list of all the ICASAs. And Nkandu, who was here, was the Minister of Health at the time. And two physicians who were working in the US HIV program were at this ICASA. I was working in the government at the time for the Minister of Health, and she invited me to go to these international meetings so we could find out what was going on. And these two doctors, with me, visited a rural hospital outside Lusaka. And it was run by a faith-based organization. And these two doctors went into this hospital, and they're walking around, and most of the people were in the hospital with PCP pneumonia. In the early days, that's who was in the hospital. And they looked at each other and they said, we could treat this, and these people do not have to be in the hospital. And this is way before ARVs. This was just about treating pneumonia and getting people home and creating space where people could get support where they were and not have to be in the hospital. And those two doctors both had a run as the head of PEPFAR. One of them's name was Joe O'Neill and the other one's name was Eric Gooseby. And those two physicians met with President George Bush at the same time organizations were around the world saying we need to change the response and from doing nothing to doing something. Those two physicians, from their experience at ICASA, convinced the president to do a program that became PEPFAR. So you never know. If you have something to say, something to offer, something to show, something to express and explain, you might want to take a risk and do it. Believe that you can. Don't go where you get a no, and act as if. I leave you with that. Thank you.